to the orthopedic surgeon and which pathology should stay and not leave the primary care physicians, the family physicians, hospices, or the pediatricians. So if you may allow me to introduce this, that, generally, I'm sorry, these windows keeps popping. So generally, historically, the MSK problems is quite common and should be placed greater to emphasize on MSK training. We know that most of the presentations of the cases to the emergency department in the hospitals and in the hospices as well are MSK problems. So that's why we need to have a better focus on MSK problems. They account about to 30% of cases. In the past, there was many trials to understand the MSK problems and to put them together. So when a case that has an orthopedic issue comes to a hospice, our family physician or our general practitioners or our colleagues from the pediatrics will know how to deal with it rather than sending it to the hospitals. But the difficulties here is there because there's many obstacles. One of them is we lack, or generally I personally lacked the training of MSK when I was in medical school. So we don't get taught orthopedics in medical school. We get taught general things like general surgery, ENT, ophthalmology, and those are more focused generally on than orthopedic surgery. The other thing is, even within the residency programs, the MSK is not very well looked at. So that's why we have to change probably the wheel. Previously, there was guidelines done by different hospitals to just guide the non-orthopedic surgeons or doctors to understand how to filter those cases, which goes to the hospital and which stays in the hospice, and which needs to be operated, which needs to be observed. And these guidelines helped the doctors how to talk to the families and how to reassure them and how to tell them all the details about the case before sending it to an orthopedic hospital. So these guidelines were done by the American Academy of Pediatrics. It was voluntary guidelines. It was an attempt to establish diagnosis. They were useful, but sometimes we do have some lack of facilities in our hospice. So maybe you don't have a cast or a good dressing room, or maybe you don't have an X-ray to take an opportunity to check the child or to X-ray his trauma before you send it. So I went through the literature. So I was like, why do we still get in, for example, in my clinic, in orthopedic clinic, we do get some cases that should be treated in the non-orthopedic hospitals or in the hospice. So I looked into one of these papers that they were checking their referrals generally. And those referrals, they were trying to convert the diagnosis that the primary care pediatrician or pediatric providers believe that are commonly needed to be referred to the pediatric orthopedic service. So they reviewed almost 300 files and they filtered them according to the type of referring provider and the diagnosis of the referring provider and the diagnosis of the treatment and the plan of pediatrics ortho. And interestingly, it was found that, only 58% of the cases were having a proper referral, not the diagnosis. So almost 60% are having a good reason for referral. And it's only almost 40% out of this 60%, which means it's 20% of all referrals are having the proper diagnosis. So this is actually, it's a big issue. So this means if you take all the referrals from the family physicians or pediatricians or the general practitioners and filter them, you'll only find 20% only correct referrals. This is actually, this means, we do have an issue here. It's not our colleagues' mistakes. It's not our mistakes. It's the communication mistake. It's the system mistake. It's the educational mistake. So this paper has concluded that, there was a lot of inappropriate referrals This created a lot of burden, a lot of work that is being put on the orthopedic surgeons. This delay sometimes in the referrals can actually cause more problems, and there should be the reason here why this is happening, because there is a lack of basic textbook knowledge, and there is a lack of examination skills, and sometimes appropriate facilities. Another paper in the literature was discussing the purpose or looking into how many referrals to pediatric orthopedic hospitals specialty care are causing problems. So the purpose of the study was determining how many new referrals cases seen by the pediatric orthopedic surgeon are in fact conditions that can be readily managed by the primary care physicians. And the conclusion was almost half of all new referrals to the tertiary pediatric orthopedic clinics were found to be conditions that can be manageable by the primary care physician. So this is like a big thing. Here you stop and you say, I think there's an issue in the system. The Children's Hospital of Orange County at a certain point has went through some guidelines. It was actually very nice. So I Googled any referral guidelines any from different hospitals. I found this. It was actually somehow useful. It gives you some guidelines. It needs to be modified, need to be corrected. But it's a helpful guideline, and it went through the most common um, uh, scenarios, like the flat feet issues and in towing and etc. So it's something that puts you on a guideline. Now, what do we need to understand? Let's just take this in that way. So we need to understand that the MSK issues is one third of the medical problems in children, and it's some are common and easily precisely diagnosed. We know that some needs non-operative treatment and or reassurance can be given by the pediatricians, and occasionally a problem needs surgical treatment sometimes. Okay, so what to do? We need to delineate pediatric orthopedic problems that actually which means we have to identify the problems. So we do have actually three types of problems. There is problems that require recognition and urgent surgical intervention. So it's something that you don't want to miss. Send it directly to the hospital. And there's some other relatively common, which is not very common, but it have different treatment options that you can wait. And there is common and other problems that needs no surgical treatment and are well managed without any referral. Now, whenever it's possible, if you have a chance, if you receive a patient, you need just to focus on three things or a few things. You need to make a diagnosis before referring. So if you have a child with an intowing, so you need just to send the child to the with a proper referral, because not I mean, if you don't have the knowledge, it's not wrong, but we do get some cases that it's been already discussing the management with the family, and this makes it very difficult on us, or something that looks very vague, very 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 widely vague. So child has leg pain, it doesn't really um, trigger me to accept the case, or doesn't really trigger my understanding. So we need to make a diagnosis as much as we can. If we know what is the diagnosis, or otherwise we can describe what the child is having. And so it's better to refer a diagnosis, not as symptoms. And then we need to make the treatment plan. If we refer a child from the hospice to the subspecialized surgeon, we make the plan widely unclear when we refer it. So if somebody is coming with a DDH, for example, and he was diagnosed with a DDH in the hospice, and you wanted to refer it to the pediatric orthopedic surgeon, it's better to say they will take care of you. They will have a specific plan according to the age group. It's easy, it's common. They deal with such cases all the time. But if you tell them that you will be needing a brace, and the child comes to our hospital, and we identify that this child is actually it's an advanced case and he needs surgery, the family will be very disappointed, and they will either mal trust you or maltrust us. So we have to be, helping each other, because we don't want to, if somebody comes with you convinced by another doctor, by a plan, the burden on us is to deny that plan and convince with the new plan. So this is the issue here. So again, you need probably, if it's possible, you need to allow discussion of the natural history, if you know what the diagnosis is. Reassure the family while waiting for the appointment. And very important, I always say this, I am very actually very flexible with everybody, that please kindly communicate with the specialist doctor. I am open to communication, open for communication anytime. Most everybody in the country almost have my number. Patient has my number. Patients actually search for my number. They communicate, and then we arrange appointment. Now, so we be discussing few um, red flags, and then we will be discussing different pathologies. So, in a limping child, the situation is actually no joke, because it could be very benign, it could be very aggressive. It's a red flag. You need to recognize the problem. We need to rule out any pain and fever. We need to rule out any recent infection. Uh, having I'm sorry again. Okay. Yeah, we need to identify if the child has a recent infection. We need to make sure that there was a trauma either being witnessed or unwitnessed, because it makes a huge difference. Sometimes a child comes to your clinic with a limitation of elbow movement, and people think it's a trauma or it's a non-trauma, and then you start treating it as a bulled elbow. And then you identified that this child has a fall and he had a fracture, and then by doing the manipulation, you actually make it more worse. You need to actually rule out constitutional symptoms, and use a proper diagnostic tool. Don't mask the picture by giving antibiotics. Sometimes it's really bad if you give antibiotic in cases of septic arthritis, because it masks the picture and kills the cartilage very faster. You need to observe as well clearly, and you could this limping, it could be really serious. So if I open a question now to all, what is the difference between these three kids in terms of gait? Can somebody answer me? Can I get an answer? Any volunteer? Can you hear me? Hello?
Yes, doctor.
Okay,
The,
good. Somebody's alive. I
yeah,
thought I was talking to myself for
the
a
answer
second.
is in the chat box.
So which child has an abnormal gait? Left, middle, right.
Someone answered the first one is white gate.
So we have answers where on the chat? Yeah.
Yeah,
Will be updated later.
all normal,
All normal.
middle.
Middle, left, doctor, left, 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 left. Okay. So good. Yeah, there's who DM. I don't know who's DM. She said DA, doctor DA. I don't know. It's actually, these are three videos for the same child at three different ages. So can you believe that, this is the same child, but he's walking at three different ages. I think the left side is at 1 year. Yes, and then in the middle it's 18 months, and on the right side it's 24 months. So the reason why I'm bringing this on is to tell you that actually different age group have different gaits. So when a child comes to the clinic when a family comes to the clinic saying, "Doctor, our child is 1 year, 3 months, his feet are not really normal on the floor," I tell them, "No, don't worry. This picture goes with this age. So you have to relax. He's a normal child. He will change." And this has actually been proven here. If we repeat the videos, let me just go back and play the videos again. So if you see the left side, He's more of a flat feet on the middle of the. He's having some in-towing on the right side. He's capable of he's having actually more of straight legs. So there's differences. Even his features are different. So I brought this intentionally to trick you in that regard. But in this picture, if you look into the left side, if we play the video, this lady or this girl is walking with a short step gait, which means she's probably having issue. She doesn't want to put her weight on that side. This means she has an antalgic gait, which means it's a painful gait. Painful gait means she has generally trauma or infection or such a thing. While on the other side here, you can see her pelvis is tilting every time she walks. So she's having weaker muscles on the abductors. This means she's having a waddling gait. So waddling gait indicates weak muscles or short muscles. While this guy or this girl is having waddling gait both sides, on the right side and the left side, which means she has weaknesses on both sides. So we have to investigate, is this DDH, is this muscle issue, and etc. So why I'm bringing those videos? Because the first thing you need to identify when you actually in your clinic or in your hospice, that once a child walks in, you have to screen his gait because it just tells you everything about it. Honestly, wallahi al it tells you almost everything about why the family are coming. So I usually, when a child walks in without a limp, I think about our extremity, or I look at the age and I know from this age the family will be mostly complaining of one, two, three, four, five. Exactly. And I almost never miss when I have this in mind. So now, if we come and commonly divide the orthopedic conditions into groups. So there's groups that need surgery. There's group that maybe need surgery in the future or delayed surgery, and there's a group that needs nothing to be done and should not be coming to our hospital. So, what do we need to send directly to the hospital? If we have a child that, commonly we see somebody with the subcapital femoral epiphysis, which is a slippage on the femoral epiphysis of the femur, and we'll have a pictures after this slide. These cases has to be dealt with directly, immediately, because we need to generally operate on them by putting a pin in situ to stop the femoral epiphysis from sliding. Septic arthritis is a killer. You don't want to go to bed putting your head on the pillow while somebody is cooking sepsis on his hip or joint, because once you develop um, the pussy exudate, it starts killing the cartilage, and you might have an irreversible damage in the future, and also fractures. But there is some less common problem that needs maybe surgery, or also it's commonly. So malignancies, compartment syndrome is actually, we do see them less, but it's there. Malignancies, we also get to see them in open fractures. But what are the other conditions that you might give the family a delayed referral? So a referral within a month or two, let's say, for example. So scoliosis, it's common in adolescent and idiopathic and juvenile. DDH, this dysplasia and dislocation of the hip, they need to be referred to the pediatric ortho. Cerebral palsy, Perthes disease has to be actually referred, I would say, within a month, because it's very important. Nowadays, we came with a new technique on treating Perthes disease. It's actually helping a lot if we detect them early, and it gives a proper treatment or natural history improvement. Osteomyelitis is something that need to be seen faster. Spondylolisthesis is something that you can wait for a little bit, but still it's not an emergency. Trigger thumb, not an emergency. Benign bone tumor, not an emergency. Back pain and in young children, not an emergency. Now, what are those things that I'd rather not to see in my clinic? It's good for maybe for my private practice if I see those cases. Despite that, I just counsel them and talk to them, and I don't do any single investigation or any X-ray. So medial tibial torsion in kids, it's normal. Idiopathic tiptoeing, or a child with tiptoeing that his feet is correcting when he tiptoes and he put his heel on the ground. So these are more of habitual tiptoeing. Medial femoral torsion, which makes in-toeing, osgood slatter around the knee, bowed legs in toddlers, transient synovitis, anterior knee pain in adolescents. All these are something that, we'd rather not to see them in our orthopedic clinic. So what is slipped capital femoral epiphysis is a thing, a slippage that happens to the femoral head or femoral physis. If you can see here in the middle picture, the femoral physis has slipped from the neck. This is actually very painful. It's actually has to be operated immediately, because when we operate, we try as much as we can to stop the pain and stop the further progression. And we maintain the hip, because if it's furtherly slip, it will cause avascular necrosis and the femoral head will die. And then in the future, the child will have an artificial joint. So how do I identify them? The kids are either come with severe pain on the hip and knee, and sometimes they only come with a knee pain. So every time you have a knee pain in a child, you have to X-ray the pelvis, because there's a nerve that crosses both hip and knee joint and causes a referred pain, which is the obturator nerve. So just you have to be careful when you have a knee pain. Don't only take an X-ray on the knee, you also need to take an X-ray on the hips. The other condition that I want to mention is septic arthritis, which is something that we have to focus on. And يعني والله يعني يذكر فضل الله سبحانه وتعالى عليه. لأنك أنت, if you have a very wide open eyes, and if you have uh, a good clinical sense, you will almost never miss somebody with a septic arthritis. I have a very low threshold to operate on any child with a limitation of hip pain. And so if we have a criteria that we go with. So it's a surgical emergency, because if the child develops, especially child, if he develops a septic joint, this sepsis can go into septicemia and he might actually lose his life. So you need to treat him very quickly. So we depend on Coker criteria, which is criteria that has four points: WBC increase and the inability to put weight bear, fever, and ESR. And also CRB now has been added as a fifth factor in the Coker criteria, in the modified Coker criteria. So if we apply those on any child, you have to be careful. So if you have one factor, your probability of having a septic joint, I think, is 30%. If you have two factors, your probability to have septic joint goes to 90%, I think, or 85. If it's three, your chances of having septic joint is 95. If it's four, it's definitely septic arthritis. And the order of sensitivity of the above criteria, or the general changes, is fever get affected first, CRB increases, then ESR increases, then the refusal to weight bear, and the WBC. So then what are the conditions that do not require an immediate referral? Dysplasia of the hip, or DDH. Those are common in our country. We have hundreds and hundreds and hundreds of cases. This week, I have operated 4 kids with DDH, or 4 hips in 2 kids. So it's a lot of pressure on us to treat surgically those cases. I'd rather to treat those kids with a Pavlik harness or abductional brace in an early time of life, because we need to avoid progression of the condition and reach the surgical time. And I'm also working on, at this moment, on a national program of ultrasound hip at 6 weeks, to ultrasound everybody on that age group, so we can probably prevent further surgical treatment on dysplasia of the hip. What are the other thing? Cerebral palsy is a condition that we see quite commonly as well. It's a static disease. It's an upper motor neuron. It could affect any part of the body. Identification of those cases early is really important. Sending them to physiotherapy, sending them to every single subspecialty that those kids are requiring is really important, and it needs multiple teamwork to reach a good outcome. Those listed cases now are the cases that we probably should not see in our hospital. For example, transient synovitis. Transient synovitis is it's a transient, so something that comes and goes. It affects the hip It's a bug that reached the hip because in kids the hips can or any joint can be picking a microbe easily. And once it's reaches the joint, and inflammatory changes will happen. Not necessarily it will go into uh, pussy or infective process. It's just an inflammation. So kids in generally with transient synovitis will have low grade fever or no fever. They will have irritation a little bit, a mild limping gait. The WBC is normal. There is fever or very, very, very low threshold or low grade fever. And the child is happy, eating, sleeping, and he's doing well. And the pain comes early in the morning. It's noticed very well in the morning, according to the day, along the day, it drops and then it picks up again at night. So this is transient synovitis. We tell the family rest, Panadol, and that's maximum what we need to give, and we have to observe for other symptoms. Intowing is a common thing, mainly in kids from age of 2 till age of 9 almost. It all or mostly comes from the anteversion of the femur. They're non-operable cases. They will not change with physiotherapy. They will not correct with shoe modification. They will grow out of it. I tell families that intowing is 30% of my clinic presentation. Kids comes with toes that's pointing in. The gait is abnormal for the family. They trip a lot. They feel weak very fast, and they sit at W sitting. And I tell the family it comes in girls more than the boys, and it's more obvious in kids with generalized ligamentous laxity. And I always tell them that intowing usually improves before the age of 8, after the age of 8. So 95% of the intowers will improve before the age of 8. Um, After the age of 8, 4% will persist up to the age of 10 to 15, to 14 maybe. And there's a very, 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 very minimal chance of that we operate on those cases. In my practice, I've been an orthopedic surgeon for almost 20 years. Um, 15 years of that is a pediatric orthopedic surgeon. Uh, if you ask me how many of those cases you operated in towers, I operated on Sheikha, Hanouf, Ulujain. And the reason why they reach the age of 15 and their feet are really, really in a internal rotation position. So we gave the body the whole chance to improve, and once it didn't improve, we operated on those. And then you have the idiopathic tip walkers. They're usually habitual, medial tibial torsion, or familiar oscar slatter, and these all something that you have to observe. So we talked about transient synovitis. Idiopathic tiptoeing is usually habitual around the age up below the age of 4. It usually corrects with time. We tell the family that stretching is good. I don't think boots will do much unless we just give them the boots to change their habits of standing. But to use the boot to stop him or to tighten his feet, this is actually not good. We talked about in towing, and that's also we do have measurements and other things. So Osgood-Schlatters is epiphysitis of the growth plate on the proximal tibia. It's just painful. It's in boys more than girls. It's annoying. So we just have to treat the symptoms, and that's all. So, what is our take home message? So, before we refer anybody to the specialized doctor, um, we should probably um, if you don't know the diagnosis, you need to probably describe the signs and symptoms in a good way that you can describe the picture to somebody on the other side. If you know the diagnosis and understand the natural history of the patient or orthopedics condition, you need to provide a reassurance and initial treatment plan. Just a very, 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 very shallow plan. You need to understand emergencies such as SCIFI, septic arthritis, and orthopedic malignancy, which require surgery and should be referred immediately. And it's really advisable to communicate with a pediatric orthopedic surgeon, which will actually prevent the unnecessary referrals and reduce the burden on our clinic and our service. And you also, if possible, you need to ensure that the referrals are made in timely manner to improve the care provided by both physicians. To this point, I think I am done with my lecture, and I hope this was informative and useful to all. And I'm ready to take your questions. Thank you very much.
Thank you so much, Dr. Saleh. Much appreciated for the informative lecture.
Most welcome.
Now it's time for questions. Please, audience, do not hesitate to ask questions in the chat box.
So in the chat box, huh?
Yes.
Chat box. Mm. Does all children with tiptoeing before 4 are habitual or need to do anything investigation? Good question. So how to differentiate between tiptoeing if it's habitual or needs further investigation? I am totally against sending everybody with tiptoeing to investigation because it will put burden on the other services. So I know some of my colleagues actually in my hospital, they would refer any tiptoeer to a neurologist. I think it's needless to do this unless you're suspecting upper motor neuron. So we are doctors as well, and we know how to investigate some cases. But habitual means the child is able to stand with his foot fully touching the floor. But if he moves from one point to another, he tiptoes in his foot. So this is mainly habitual, which means it's correctable. It doesn't. It goes up and down, but he likes to tip on his toes. So that's to answer your question. The other, we would love to communicate with second doctors, but unfortunately, there are no official ways unless both parties kind enough to go out of the norms. Yes. Uh, I usually receive messages on my phone from patients and doctors and from everybody, and I organizes appointments. So appointments to the clinic and visits. So you don't have to worry about this. My number is all over the country. Trust me, wallah. And then when do you intervene in births? So that's a tricky question because births is actually a disease that needs interference according to many things. It is according to the age, um, the level, or the stage of the disease. So in births, I can interfere as young as 4 or 5 years because despite the fact and the literature knowledge that states that the younger the child with births, the better the outcome, we've been seeing the opposite. Nowadays, I've been treating older kids with births with early first presentation around the age of 9. So I've been going with all the weapons at that age group surgically, I know, and I tell the family this is an actually aggressive treatment, but it's been coming actually with a very, very, very good outcome. Alhamdulillah, we're writing actually a paper on this. Any other questions?
Thank you again, Dr. Saleh. It was a clear and to the point lecture. I think we have also one question.
So,
You don't mind to answer?
yeah, sure. When a patient refers to you with a fever and limb gait, do you need to go for X-ray to differentiate between? No, X-ray wouldn't really show. So if you do X-ray for septic arthritis or transient synovitis, you're just ruling out other things. But do you recognize anything? And can you see transient synovitis with a septic arthritis by X-ray? You might see a shadow of the hip joint that is actually being enlarged. You might, not always. But the proper tool actually of diagnosis is aspiration. So proper tool, if you have all this criteria factors on, you tell the family انا والله بروح العمليات وسوي كذي. يعني دائما اقول لهم مثل انت لما تشم ريحه احراق او دخان في بيتكم ما تقعد تحط راسك على المخده، تروح تبطل البيبان وتتاكد انه ماكو شيء قاعد يحترق. ف aspiration is actually a good tool. And طبعا MRI is more diagnostic tool as well. Regarding referral, it would be helpful that in the national program of ultrasound, the family physicians can be given the opportunity to participate and send patient directly to ultrasound. أتمنى هالموضوع يكون موجود لأن I would love that the patient are referred to us after ultrasound, not to us with ultrasound. So you screen, and if you find something or if a positive ultrasound is there, that you have to send it to orthopedics. But we don't have to screen and follow, because we do have actually, the clinics are really, really, really tough on us. This is all the questions I've answered.
Thank you. That is all question. Thank you again, Dr. Salleh. And now we will move to the next lecture. I would like to hand over to my colleague, Dr. Ali.